So, think about this for a second. If you break an arm, an X-ray shows exactly where the bone snapped, right?
Yeah, it's just a clear, jagged white line on a black
That's
background.
exactly. The doctor points to it, they put a cast on it, and, well, the problem is visibly solved.
Which is comforting, honestly, because we all like things to be categorical and simple.
We really do. But what happens when a patient walks into a clinic, describes a severe, physically life-altering symptom, and the objective physical exam shows absolutely nothing is wrong?
Oh, I mean, that is the ultimate diagnostic headache. You step completely out of the realm of simple mechanics, and you
Yeah.
enter this landscape where human perception and physical reality are just completely at odds.
Which brings us to our mission for this deep dive. Welcome in, by the way.
Yeah.
We are tackling a highly sensitive, widely misunderstood, and heavily searched question for you today.
And it's a big one.
It really is. The question is, can the vaginal opening actually be loose while the deeper vaginal canal is perfectly normal?
It is such a brilliant question, and the short answer is a resounding yes. But the mechanics behind it, the reasons why it happens, they completely defy common sense.
Yeah.
To really understand it, we basically have to throw out the mental model most of us have of human anatomy.
And to do that, we are stacking up a pretty diverse pile of sources today to get to the bottom of this for you.
Yeah, we're pulling from clinical guidelines like NICE and RTOG.
We've also got advanced biomechanical research from Frontiers, anatomical MRI studies from AJR Online, and this really eye-opening clinical study called Develops.
Plus some incredibly practical insights from gynecology clinics, like Pelosi Medical Center and the Women's Health Clinic.
So we have a lot to cover. And like you teased a second ago, the answer to our core question is yes. The opening can be loose while the deep canal is totally fine.
Absolutely.
And I know the mechanics behind this, which involve like 90-degree angles, trapped air, and this massive disconnect between how we feel and what is physically real. It's going to completely change how you view the human body.
I mean, we really do have to throw out the idea that the vagina is just this one uniform, simple tube, like a pipe.
Right, because if a pipe is stretched or compromised in one spot, the assumption is the whole system is failing.
Exactly. But when you look at anatomical MRI studies, like the ones from AJR Online, that whole pipe metaphor just falls apart immediately.
Because the anatomical reality is just so much more intricate than that.
It is. Researchers actually describe pelvic support in 3 distinct levels. It really helps to visualize it not as a single pipe, but as a hallway and a doorway.
A hallway and a doorway. I like that.
Yeah. So the deepest part of the vagina levels I and 2, which we'll call the hallway, it's suspended by this really complex web of fascia and ligaments.
Which are attached high up to the pelvic sidewalls, right?
Right. And the sacrum. It's highly structured, so it's essentially hanging from the ceiling and the walls of the pelvis.
But the opening, the introitus, or level 3, is built entirely differently.
Completely differently. It is not suspended from above at all. It is fused directly to the perineal body and the surrounding pelvic floor muscles at the base.
Okay, let's unpack this. So the doorway is basically anchored to the floor, while the hallway is hanging from the walls and the ceiling.
That is exactly right. And because these support systems are functionally independent, trauma doesn't affect the whole structure uniformly.
So is this basically like a drawstring bag where the top string got stretched out or snapped, but the fabric of the bag itself is totally fine and tight?
That is a perfect way to visualize it. It's a localized mechanical failure. And, this distinction isn't just some anatomical curiosity for textbooks.
Right.
It is the absolute cornerstone of clinical treatment. The guidelines from bodies like NICE, the National Institute for Health and Care Excellence, and RCOG, the Royal College of Obstetricians and Gynecologists, they specifically mandate that doctors cannot treat pelvic floor dysfunction as just a generalized issue.
They require doctors to grade the anatomy compartment by compartment, which makes sense when you think about the drawstring bag.
Exactly, because if a clinician just hears a patient complain of looseness and they assume the whole pipe is broken, the surgical consequences can be disastrous.
Wait, really? Disastrous how?
Well, the experts at Pelosi Medical Center highlight this specific phenomenon. Let's say a patient comes in with a loose opening, but a tight, deep canal.
This snap string, but a good bag.
Right. If a surgeon performs a full vaginoplasty, meaning they tighten the entire length of the hallway, they are operating on perfectly healthy tissue.
Oh, wow. Which means they end up over-tightening a space that was already functioning normally.
Exactly. And that results in severe pain during sex and a whole host of new mechanical problems.
That sounds awful.
It is. Instead, recognizing this as an isolated level 3 failure means the correct procedure is a perineoplasty or a perineorrhaphy.
Meaning they just repair the weakened perineal muscles right at the entrance.
Just at the entrance, you rebuild the doorway and you leave the perfectly normal hallway completely alone.
Okay, wait, hold on. If it's just a muscle tear at the entrance, say from childbirth or chronic constipation, why doesn't it just heal?
What do you mean?
Well, like any other cut or tear. You get a cut on your arm, it scars over, and you move on. Why does this specific damage stay permanently isolated at the opening? Why doesn't the body just tighten it back up?
Ah, well, if we connect this to the bigger picture, to understand why it doesn't just knit back together, we have to look at the biomechanics of the pelvis.
This is where that advanced research from the journal Frontiers comes in, right?
Yeah, that study changes the game. See, the pelvic floor is a dynamic equilibrium system. It relies on this brilliant triangular support structure.
Between the bladder, the uterus, and the levator plate, which is basically the main muscle shelf of the pelvis.
Exactly. And the most critical feature of this whole system is its geometry. The vagina does not go straight up and down.
Right. During normal function, it actually has a 90-degree folding angle. It's almost like a kink in a hose.
That angle is everything. It is the body's primary defense mechanism against gravity and pressure.
Because whenever you cough or laugh, sneeze, or lift something heavy, the intra-abdominal pressure inside your body spikes dramatically.
Yes.
Right?
It's like a small bomb going off in your abdomen. And because of that 90-degree angle, the uterus is pushed in a downward-backward motion. It acts kind of like a piston in a cylinder.
So the angle basically serves as a mechanical backstop.
Precisely. It takes all of that immense, explosive downward force and redirects it backward right into your tailbone, the sacrococcygeal axis.
Meaning the force is absorbed by solid bone rather than just blowing straight down through the soft tissue of the vaginal opening.
It's incredible engineering. But that brings us back to your question about the tear. The sources cite vaginal deliveries, especially with prolonged pushing or large babies, as well as chronic constipation as the main culprits for damaging that perineal body.
And when the perineal body, the anchor at the entrance, gets damaged, it physically shortens. The Frontier study noted that a traumatized perineal body can shorten by 30 to 50%.
30 to 50%.
So almost half of the anchor is just gone.
And that shortening ruins the geometry of the entire pelvic floor. When the perineum shortens by that much, the angle of the levator plate changes by 15 to 25 degrees.
Oh, I see. So the protective 90-degree kink is basically erased.
Exactly. The vagina becomes far more vertically aligned.
Which means the backstop is gone. Now, every single time you cough or laugh or just stand up, those stress vectors from your abdomen aren't hitting the tailbone anymore.
No, they are not.
They're being funneled straight down into the vaginal introitus, the opening.
It creates a relentless downward pressure. The opening got damaged initially, which changed the angle, which now constantly funnels all the body's physical stress right back onto that exact same damaged opening.
It's a vicious cycle.
It really is. This constant biomechanical battering literally prevents the entrance from tightening back up.
Yeah.
It forces the doorway to gape open permanently, even if the ligaments suspending the deeper hallway were totally untouched.
Here's where it gets really interesting, because this gaping entrance doesn't just look different on an MRI. It actually changes the physics of how the body interacts with the air around it.
It absolutely does.
When the entrance is wide open but the deeper canal remains tight, it creates a very specific fluid dynamic situation.
You are referring to vaginal wind.
Yes, colloquially known as queefing. According to clinical overviews from sources like Kegel 8 and the Cleveland Clinic, over a third of women with weakened pelvic floors experience this regularly.
It's extremely common.
But rather than just being something to be embarrassed about, the mechanics of it are this fascinating real-time demonstration of this exact doorway versus hallway phenomenon.
The physics play out perfectly here. Because of the altered angle and the shortened perineum, the patient has an enlarged genital hiatus, meaning a loose doorway.
So air can very easily flow into the lower vaginal canal.
Exactly. This frequently happens during inverted yoga poses, for instance. Gravity pulls the internal organs downward, creating a vacuum effect that actively pulls air in. It also happens a lot during penetrative sex.
Right, so the air gets past the loose entrance, but then it hits the deep canal, the level lion 2 hallway, which is still functioning perfectly.
And that deep, healthy tissue is naturally taut, so it acts as a pneumatic seal. The air passes the loose doorway, hits the tight hallway, and becomes trapped in that middle space.
It's essentially air getting past a faulty intake valve, but then hitting a solid wall.
Exactly. Then, when the person shifts position or stands up or the external pressure changes, that trapped pocket of air is rapidly compressed and expelled back out through the loose opening.
And the vibration of the tissue as the air escapes creates that sound.
Right. A sound similar to flatulence.
So if you've ever panicked about this or felt deeply embarrassed, please hear this loud and clear.
Mhm.
This is completely normal physics. It is an odorless mechanical quirk of having an open doorway in a tight hallway.
It's literally just trapped atmospheric air.
Right. The only clinical caveat, which the Cleveland Clinic is very clear on, is if there is a foul odor or if stool is passing through the vagina.
Yes, that is a crucial distinction. That specific symptom could indicate a fistula, which is an abnormal tear-induced connection between the bowel and the vagina, and that requires immediate medical intervention.
For sure. But standard, odorless vaginal wind is purely a mechanical reality of this altered 90-degree pelvic angle. Okay, so we've mapped out the physical reality. We know how the perineum shortens, how the angle fails, and how the air gets trapped. But how accurately can a person actually feel these mechanical changes?
What do you mean?
Like, if the physical doorway is loose, does the brain register it accurately?
Oh, this is where the clinical data challenges everything we assume about bodily awareness. What's fascinating here is a study called Developus, published in the journal Sexual Medicine.
Right, they set out to investigate this exact correlation.
They did. They wanted to see if a woman's subjective feeling of being loose actually matched her physical, measurable anatomy.
So they took a group of sexually active women and gave them the vaginal laxity questionnaire, the VLQ, asking them to self-report their sensation of looseness.
And then doctors performed highly objective POPQ physical exams and used ultrasounds to measure the actual physical caliber of the mid-vagina.
Which you'd think would line up perfectly.
The researchers expected to find a straight line between the feeling and the physical measurement, but instead they found absolutely no significant correlation. None. A woman's subjective feeling of being loose had no statistical relationship with physical pelvic organ prolapse, nor with the actual diameter of her vagina measured on an ultrasound.
That is wild. So a woman could write on the questionnaire that she feels incredibly loose, but physically measure on an ultrasound as completely average, or even tighter than average.
Yes. Our internal sensation of our own pelvic anatomy is shockingly unreliable.
But why? I mean, why would a younger woman with completely normal, tight anatomical measurements feel loose? Is the brain just making it up?
It comes down to how the pelvic region is wired neurologically. See, the vagina does not have the same kind of dense, high-resolution sensory nerves that your fingertips do.
Right. Your fingertips can easily tell the difference between a coin and a paperclip.
Exactly. But the deeper vaginal canal, the hallway, is innervated primarily by the autonomic nervous system. It is very poor at detecting localized, absolute dimensions like width.
It can't exactly pull out a mental tape measure.
No, it can't. It relies heavily on secondary cues, primarily stretch and friction. The lower third, the doorway, has more somatic sensory nerves. If that doorway is just slightly altered or stretched, the initial entry friction during sex changes.
Ah, I see where this is going.
Right. The brain receives a signal of less friction at the entrance and falsely maps that sensation onto the entire canal. It interprets the whole space as loose, even if the deep tissue is wrapped tightly around a totally normal physical dimension.
So the brain is essentially taking a localized lack of friction and projecting it as a massive structural failure.
Exactly.
And the data gets even wilder when you bring the partners into the equation. The Develop study actually asked these women what their partners had said about their vaginal tone.
The results were staggering.
72% of partners had never commented at all. And of the partners who did comment, the majority, 21%, actually said the vagina felt tight. Only 7% ever said it felt loose.
The disconnect between the silent anxiety many women carry about their bodies post-childbirth and the physical reality experienced by both themselves and their partners is profound.
It really is. And there's another fascinating twist in the data regarding age and menopause.
Yes, this part is so counterintuitive.
Right, because you would naturally assume that as muscles age and go through, decades of use, women would report feeling looser. But the Develop study found the exact opposite.
The sensation of tightness actually increased with age and menopause.
Why is that?
Well, this brings us right back to the brain misinterpreting friction. During perimenopause and menopause, estrogen levels decline significantly. As the sources from the Women's Health Clinic explain, this lack of estrogen causes the vaginal epithelium, the skin lining the canal, to thin out.
It loses its elasticity.
Yes, and its natural baseline lubrication decreases.
So the physical muscles aren't actually getting stronger or tighter. The skin itself is just changing texture.
Exactly. Because the tissue is drier and less flexible, any movement or penetration creates significantly more friction. And since the brain's primary metric for pelvic dimension is friction, it interprets this dry, inflexible state as a sensation of physical tightness.
It just proves how easily our internal sensors can be tricked. The brain interprets a lack of lubrication as a mechanical tightening.
Which is exactly why comprehensive clinical assessment like the compartmentalized approach mandated by NICE and RCOG is absolutely vital.
They can't just guess based on symptoms.
No, if a patient complains of a sudden change in sensation, a doctor has to act like a detective. Is this a mechanical muscle failure at the doorway? Is it a change in the deep hallway suspension? Or is it a hormonal tissue change masquerading as a structural issue?
So what does this all mean for someone looking for a practical fix? I mean, if a patient does have that isolated mechanical looseness at the entrance, the torn perineum ruining the 90-degree angle, how do doctors actually treat it today?
Well, the universally recommended first line of defense before any scalpel is lifted is pelvic floor muscle training, commonly known as Kegels.
But based on the Kegel 8 and Women's Health Clinic sources, we have to clear up a massive misconception here about what Kegels actually do.
Yes, we really do.
Because they do not tighten the actual vaginal tissue, do they? You cannot shrink the skin or the mucosa of the vagina by flexing.
No, you can't. What Kegels do is they target the surrounding architecture. They strengthen the puborectalis and pubococcygeus muscles, which actually wrap around the vaginal opening.
Okay, so by actively bulking up those surrounding muscles through resistance training, you create a thicker, stronger muscular ring that artificially closes the gap.
It's like putting a thicker, heavier frame around a stretched-out door. The door itself is still stretched, but the bulky frame is holding it tighter and providing much better support.
And that thicker muscular frame decreases the size of the genital hiatus, which helps immensely with symptoms like vaginal wind, right?
Exactly, by preventing the air from entering easily in the first place.
Okay, but what about the energy-based devices? Because the internet is absolutely flooded with clinics marketing vaginal rejuvenation using lasers.
Ah, yes. So devices utilizing CO2 lasers, or radiofrequency, they heat the superficial layers of the vaginal tissue. This thermal trauma stimulates collagen production and increases blood flow to the area.
I mean, they sound like a magic wand.
They do, but the Cleveland Clinic issues a very firm warning on their limitations. These lasers can be highly effective for improving the health of the mucosa. They help reverse the thinning and dryness associated with the menopause twist we discussed earlier.
But they cannot fix biomechanics.
Exactly. They cannot repair a torn muscle.
You can't laser a snapped anchor back together. I mean, if that perineal body is physically ripped and the 90-degree angle is gone, stimulating collagen on the surface isn't going to stop the downward funneling of abdominal pressure.
Which brings us back to the surgical option. If conservative treatments like rigorous pelvic floor physical therapy haven't resolved the mechanical symptoms and the doorway is genuinely compromised, the most effective permanent fix is targeted surgery.
The perineorrhaphy we mentioned at the start.
Yes. As detailed by clinical sources like Tabibo and Dr. Pelosi, it's a really focused 30 to 60-minute outpatient procedure.
Oh, wow, that fast.
Yeah. The surgeon just identifies the separated, weakened perineal muscles at the opening, clears away the scar tissue, and physically sutures them back together.
They rebuild the anchor.
They rebuild the anchor, and crucially, they leave the deeper, perfectly normal canal entirely untouched.
So it restores the physical doorway, reestablishes that crucial 90-degree angle, and finally stops that vicious cycle of downward pressure funneling into the opening.
It is a highly specific mechanical fix for highly specific mechanical failure.
That makes perfect sense. So we started this deep dive with a mission to find out if the vaginal opening can be loose while the deeper canal is perfectly normal. And the answer is a definitive yes.
Absolutely.
Due to localized trauma, often at the perineum from childbirth or chronic straining, the crucial 90-degree pelvic angle can be destroyed. And this alters the physics of the body, funneling physical stress directly onto the entrance, trapping air, and changing the mechanics of the pelvic floor, even when the deeper suspension ligaments of the hallway are totally fine.
But the journey to that answer also revealed that our internal perception is a highly unreliable narrator.
Yeah, that developed study was mind-blowing.
It really proved that our brain's interpretation of friction and stretch frequently contradicts physical reality. It creates sensations of looseness or tightness that simply don't exist on an ultrasound.
It leaves you with a fascinating question to explore on your own, beyond just the clinical data we've discussed today.
Oh, definitely.
When you consider this precarious 90-degree angle, this kink in the hose that is so vital for pelvic support but so easily destroyed by childbirth, it raises a bit of an evolutionary paradox.
It really does.
Humans walk upright on two legs, which requires a narrow bipedal pelvis. Yet we birth infants with massive brains. Is this entire vulnerable pelvic floor structure actually a drastic evolutionary trade-off?
A necessary, fragile compromise just to keep our organs from falling out while we walk on two legs.
Exactly. It makes you view the trauma of childbirth not as a failure of the body, but as the friction of human evolution playing out in real time. Something for you to think about. That's all for this deep dive. We'll catch you next time.